So the next speaker is Neil Desai. I don't see him here. No, that's me. Excuse me. Okay. Thank you for the invitation to be here. It's my pleasure to speak again about NAB-related technology. This is now not Abraxane, but a different drug using the same technology. So we're building on what we learned from Abraxane and using it for a different molecule, in this case an mTOR inhibitor, which is a sirolimus or rapamycin. And we have a lot of data behind this. Of course, I can't show all that, so I'll try and give you a quick background. The point is that there's a couple of mTOR inhibitors that are already approved, but there's clearly a way to improve on that. And we saw that in the case of this albumin-based delivery platform with the earlier drug Abraxane, and we believe that some of the same improvements we can make using the albumin-based technology for mTOR inhibitors, like tumor penetration and better PK profile and safety, etc. So we've already established one of the modes of transport to the tumor or to tissues where there's inflammation or where the remodeling occurs. And that seems to occur primarily through caveolar-based transport. And it's indicated here in these cartoons where the albumin drives the bound drug through these caveolar processes, through a process called transcytosis, into the area of interest, say in this case in tumors, or in areas of inflammation or where there's proliferation happening. And so we try and leverage that with this drug now using mTOR inhibitor. So mTOR inhibitors have sort of very interesting different types of activities, and certainly all of them have not been exploited clinically. So that's one of the goals that we want to do. And it's not just in cancer, but outside of cancer as well. So we know that mTOR inhibitors are very important in protein synthesis. So inhibition can decrease mRNA translation. It affects the cell cycle. There's immune modulation, so you have increase in autophagy and antigen presentation, and so there's a different type of application that could be used there. You can even get immune stimulation, and for CD8 positive T cells, increases T cell memory. So when you think about vaccines, etc., it might be interesting. And a whole other area of it is metabolic related, and there's a shift from amino acid metabolism or catabolism and away from glycolysis towards amino acid metabolism. So that is important in different diseases as well, and also alters the glucose and lipid metabolism. So you could apply it not only in sort of the cancer setting, which we are focusing on, like in pediatric tumors, or in diseases like pulmonary hypertension, which I will speak more about today, but in immuno-oncology type applications and in, for example, in mitochondrial disease. So again, this is a background slide just to show that this drug works better than the conventional drugs when you dose. This is in a typical xenograft model, bladder cancer in this case. You dose, you dose at equal drug levels. So for example, the red curve here is equivalent to 2 oral drugs, everolimus and oral rapamycin, and you get a much better outcome in terms of tumor burden and survival. And of course, you could go up much higher in dose if you need to, because the safety profile is quite different. So we want to translate that into the clinic and find the right clinical indications to go after. So in drug development, as you know, the selection of clinical indications is probably prime importance. And a failure of a lot of good drugs is probably due to poor clinical strategy. So we have to think about it very carefully, spend a lot of time, and focus on the right indication. And hopefully, after all that, we made the right choice. So one of the things we're going after is a sort of in the rare disease area, looking at a disease called PEComa. And I'm sure many of you have not heard about it. A lot of clinicians haven't heard about PEComa either. But it's a very rare form of sarcoma, and I'll explain a little bit more. And it's extremely rare. There's probably only about 200 patients in the US alone, and similar populations, 200 to 400 in Europe and elsewhere. So there's a very good reason and rationale to go after that, and I'll explain that. We're going to go after pulmonary hypertension, similarly a relatively rare disease, but debilitating disease, and I'll explain the rationale for that. We're going after rare pediatric tumors, and again, there's a very good mTOR-based rationale for use in pediatrics. I won't have time to get into that today. And then several other solid tumors, and we have studies that are ongoing in these settings. Let's talk about PEComa. You've seen these pathway diagrams before, but interestingly in PEComa, which is, as I mentioned, a very rare form of sarcoma, it happens that this disease is primarily driven through mutations in mTOR. And there's a TSC1, TSC2 complex, which is part of the mTOR pathway that ultimately leads to upregulation or control of mTOR. In which case, in this disease, there are often mutations and deletions of TSC1 or TSC2. And then because this is a negative regulator, you get an extreme upregulation of mTOR, and then you get proliferation, et cetera. And this is a very interesting disease. It has no specific organoid features, but the importance is that it has a very sort of a dual immunoreactivity of melanocytic and smooth muscle cell features. So it's a very unique disease. And so what are we doing here? We have initiated a phase 2 trial, and because it's a rare indication and there's no prior approvals in this setting, we have the opportunity for a fast track, small number of patient study, and a response rate endpoint for approval if the drug works as promised. And so, like I mentioned, the PEComas are these mesenchymal tumors which have these unique features. No prior approvals, which is an important factor. And we talked to the FDA about this, and they agreed with our strategy. So we've gone ahead and initiated that phase 2 trial. So it's in process right now, and so I can't share any clinical data about that, but we're excited about the outcomes. And hopefully 2018, we'll have some clinical data to share. So that's one of our primary studies. The next area is pulmonary hypertension. You know, we talk a lot about cancer, but I think I want to focus on a cardiovascular disease which has mTOR as its basis as well. And the cardiologists in the room, I'm sure, are familiar with this disease. But again, it's a proliferative disease, and it's a diffuse disease in the lung. And if you look at the cross-section of the blood vessels, these are normal blood vessels. But what happens in pulmonary hypertension is you get proliferation inside the pulmonary arteries for various reasons. These arteries are narrowed down, and then there's the heart has to pump with a higher pressure against these vessels to get oxygenation into the lung, which eventually then leads to right heart failure. So it's a very complicated disease. It's a debilitating disease, and it is driven by proliferation. And to date, there's been no approvals in this area that address the proliferative biology of the disease. It's all the therapies that are there are looking at symptomatic relief, which is, you know, how can we expand the blood vessels to temporarily create better oxygenation. So these are, for example, the prostacyclin analogs, the ERAs, PD5 inhibitors, et cetera. So essentially, this is Viagra for the lungs. And that's not a joke. It's mechanistically, that is what is happening. So we want to look at it in a different way. So can we address the biology of the disease and stop the proliferation? And if you look at this, these are survival curves in this disease. These patients are classified into different classes, just like you have, for example, in cancer, you'll have grade 1, grade 2, grade 3, grade 4. Here you have a functional class that describes the performance status of the patient. And in these functional class 4 patients in particular, and even 3, you can see the survival curves. The median survival is less than 2 years. So this is, you could say this is a cancer-like indication. It is proliferative biology. The patients don't live beyond 18 months to 2 years, especially if there is a functional class. So there's a great unmet need. And none of the drugs that are out today address this at all. So we want to see if we can sort of make the leap of faith, use the science behind it, and try and get to the heart of this disease. No pun intended. Once again, the mTOR pathway is critical. I won't get into this again. But here's, for example, a cartoon of the normal vessel, what it should look like. In the case of the pulmonary hypertension, you see an intimal thickening. You get a remodeling of the vasculature, and you get deposition, proliferation of smooth muscle or endothelial cells. And based on the mechanism, if you have rapamycin or mTOR inhibition exposure, you can reverse this process. So that's what we're trying to achieve. Now, do we have any data to support that? So these are animal model studies. This is an animal model of pulmonary hypertension. It's induced by monocrotaline, and you can see the model here. So what happens, this is the control. You have 3-week treatment of monocrotaline. You can see the vessel, and then after 4 weeks, you've developed the disease. And similarly, here is a treatment. Once you've developed the disease in the animals, here's a cross-section of arteries, then you come back with rapamycin, and you can see the reversal. So that's what we hope to achieve. Once again, looking at the biology, this is the proliferative biology inside the blood vessel. The current drugs address only this aspect. It is trying to get the vessel to vasorelax and increase oxygenation, but it do not address several of the other issues of remodeling and inflammation and thrombosis, etc. So we're trying to address that using our drug. So we have a planned phase 1 clinical trial, so we should start that up this year, and we will look at the treatment, do a dose escalation, and see how it works out after 16 weeks of therapy. So what are the other clinical programs? We have our registration trial, which is well into phase 2 right now, and then the rest of the studies we're doing in cancer and bladder cancer, pediatric tumors, which we will start shortly, pulmonary hypertension, and we are looking into mitochondrial disease. Of course, to do all this, we need money. So we just announced Monday this week that we had completed our Series A, so we're happy about that, and we can pursue our programs. And I'd like to stop there and be on time as the chair of the session, and I thank colleagues and who have helped participate in this. Thank you. Questions?
Very nice presentation. What about immunological use of this design? Because you're at the heart of a therapy that is also being used as a major immune suppressant, for instance, in organ transplantation, etc.
So we haven't focused on prevention of rejection. I mean, clearly, rapamycin is active in that setting. And maybe down the road is when we could focus on, we can't focus on everything. As a small company, we have to pick our horses. And so that's our strategy to begin with. But once we hopefully have approval in one setting, then we have the game changes, and we can expand out into other areas. Okay, I can't ask myself a question, so I think we'll go ahead. So the next speaker in this session is Dr. Heinrich Haas, and he's a well-known, oh, sorry, was there one question? Okay, sorry, but I think I've Okay, 30 seconds. Okay. Okay.
Is it working?
Yeah.
Yeah. Yeah, good to see that this drug is going for a clinical study. From my experience, this rapamycin, it is much less soluble than paclitaxel. So the way that dose is decided that when it is in systemic, the concentration shows that there is no particle should be completely dissolved in that. So rapamycin being very less soluble compared to paclitaxel, do you think that the very low solubility would be a dose limiting factor because of that very low solubility?
I'll answer your question very quickly. No. But to be, we don't see any issue with that. We've done, our phase 1 studies have gone to a maximum tolerated dose of 100 milligram per meter square, which is much higher than conventional mTOR. And basically, we don't have that issue. But we can take that offline and discuss it in the interest of the session.
Okay. Thank you.
Okay, so our next speaker is Dr. Heinrich Haas. He's a well-known face here. And he's going to speak to us about RNA lipoplex nanoparticles for tumor immunotherapy.
Yeah. Okay.